wanted to highlight this. I'm very proud of my involvement in this project called the STAR Bioresource, which is a joint endeavour between Tallaght and St. James's Hospital. It's a COVID bioresource, and I just want to share some of the things that it has taught us about COVID, and I think it shows the power of collaborative research in Ireland. It's a collaboration between clinicians and researchers and between the two hospitals. Oops, the slides have frozen. So what this project, I think, has taught us over, or what we've had to learn over since COVID arrived about a year and a half ago on our shores, was really trying to understand what makes people sick, why some people, you know, seem to get off relatively lightly when they're infected with SARS-CoV-2, why some people get much sicker, and then why some people stay sick for a long period of time. And I think, I'm sure everybody in the audience at this point knows somebody who's suffering from what's called long COVID. And we have many staff in both Tallaght and James's hospitals that are still out of work as a consequence of their infection with COVID. So I think it's becoming an increasingly important question. So one of the things that's really interesting as a clinician looking after patients with COVID is this highly variable clinical course. So everybody is infected essentially in the same way, usually through inhalation of aerosols or droplets, or through touching droplets containing SARS-CoV-2 virus and touching mucosa with them. So the infection route doesn't really vary, but what does vary hugely is how the patient responds to that. So many people have had or will have very mild COVID with minimal symptoms, no symptoms, and some people become very severely unwell, and it's predominantly a respiratory disease. Acute COVID. So they develop these infiltrates in their lungs, they have difficulty oxygenating their blood, they may require very, very high amounts of oxygen or ICU admission for intubation and ventilation. And again, as a clinician, severe COVID-19 is pretty unique in that it is so focused on the respiratory symptoms or the respiratory issues. So I would have looked after many patients with sepsis, for example, or influenza or other infections throughout my career as an infectious diseases specialist. And in those cases, people tend to have multi-organ failure. So their kidneys will fail, they might need dialysis, their brain will fail to some degree, they might have a delirium, their heart, they may have issues with their heart, whereas COVID seemed to really hone in on the lungs in a way that still I don't think is fully understood. I don't think we still fully understand the pathology. And it was very clear as well that in COVID, because people were infected and generally for the first week they were relatively well, and they started to run into trouble as their immune system ramped up its response to the virus in the second week of infection. So very much looking like an immune mediated illness, where rather than the virus per se causing the person to be sick, it was very much around the immune response to the virus causing the host problems. So this is work that we did in the collaboration with Tallaght, looking at host predictors of severity. And as you mentioned in that kind introduction, I'm obsessed, I think it's fair to say, with the effects of social determinants on health. So socioeconomic status, other social variables, and how that affects people's health. And we know that people who are less well off, less well educated, have less status in society, that they're under much higher levels of psychosocial stress. And animal models had shown that this was associated with a chronic inflammatory state. So obviously in humans, there are factors like smoking, diet, exercise, lots of other variables that are part of how social factors affect our health. But in animal models, you can correct for all of those. And you still see this chronic inflammation in animals who experience social stress. If we're looking at that in a human cohort, there are several ways to look at it. Education, employment, and wealth are different ways of characterizing people's socioeconomic status. And work, for example, in TILDA, which is the Irish Longitudinal Study on Aging, it showed that education is a really good marker of socioeconomic status. My clinical work is with people who are socially excluded, which would be characterised in Ireland at the moment very much by homelessness, as we have such a housing crisis. So homelessness is a very good marker for social exclusion, which you can really think of as being poverty in a much more extreme state. So poverty on stilts, or poverty with the volume of the effect of that on your health ramped right up. And when we looked at predictors of severity in people who presented with COVID to the hospital and were followed throughout their inpatient course, you can see that things that were associated in other countries, such as male gender, being a smoker, clinical frailty score, which is CFS, being frail, all of those things were associated strongly with severe COVID. But the strongest association was between homelessness and severe COVID. And I'm going to come back to this a little bit later when I'm talking about the vaccine rollout, because I'm really proud of how Ireland has managed, both through vaccination and through other measures, to protect socially excluded people from a lot of the brunt of COVID-19. And then this data is looking at ICU length of stay, which again is a marker of severity of disease. We've looked at lots of markers of severity, and they're all associated with education. But you can see there very clearly that people with primary levels of education, so they'd left school before completing secondary school, were at much higher, had much more severe COVID disease than people with higher levels of education. And this remains when you correct for age and smoking. And so in our data, I think it's very clearly coming across the effect of social determinants of health on COVID severity. And we're trying to tease out the immune mechanisms underlying this. So the next thing that we found in our STAR bioresource was trying to understand what's going on in acute COVID. What's the immune system doing that's making people so sick? And we took, I think we had 70 people in this study. We now have more than 900. I think we're up to 1,000 now in our cohort. So this was early on. And we characterized their clinical course, their demographic background, and also their immunology in collaboration with the immunology lab in St. James's. And what we found, we've lots of beautiful graphs, but basically we confirmed what other centres had seen in terms of evidence of inflammation. So CRP and IL-6 are both markers of acute inflammation, which is your response to infection or to tissue trauma. They were elevated, and neutrophils were up with lymphocytes going down, and the relationship between the two, how high your neutrophils were, how low your lymphocytes were, was a predictor of disease severity. And this was clinically, I found really helpful when I was seeing patients. If I saw somebody with very low lymphocytes and relatively high neutrophils coming in, they went on my I'm worried about list, and they'd be the ones that I might ring up in the evening to check on how they were doing. And then what we also saw was we saw activation of CD4 and CD8 cells, as you would expect. We also saw evidence of cells really being rushed out of the bone marrow before they were fully ready. And so we saw lower levels of CD10 expression and lower levels of HLA-DR positivity in cells from people who are more severely unwell. So we identified this new phenotype of emergency myelopoiesis, so the bone marrow pumping out these immature immune cells, which may behave in a different way to more mature immune cells. So that was another nice finding from our collaboration. Another thing that we found was looking at blood clotting. So I think it's increasingly emerging that there's something funny going on blood vessels, and as a result with clotting markers in the blood, because you can imagine when the blood vessel walls are damaged or activated, you're having lots of little blood clots. And this was work that we published looking at D-dimer, which is a marker of blood, a breakdown product of blood clots being elevated in clotting in COVID-19, and people who were more severely unwell had evidence of this sustained endothelial cell activation. So that's really intriguing because it's a potential target for therapy. So this is what we found about acute COVID, acute inflammation, and this emergency myelopoiesis, or these immature blood cells, immune cells being pushed out of the bone marrow, and something funny going on in the blood vessel wall. These are hints, and obviously we're exploring these further. And I think the final thing, and I've alluded to this already in terms of trying to understand what's going on in COVID, is around recovery. So some people recover from COVID, some people don't. We demonstrated that D-dimers stay very elevated, way beyond what you would expect. So looking like that endothelial activation is still there many, many months after infection. And that we also see persistent T cell activation, whereas those inflammatory markers that we had talked about all went back to normal. So it's definitely something funny still going on in the immune system and in the blood vessel walls. But we didn't see, what we saw that was associated with being more likely to have long COVID was being female, unfortunately for us females, and having a history of anxiety and depression. Disease severity wasn't predictive. Chest x-rays weren't predictive, and none of the blood cells or immune markers that we looked at were predictive of long COVID. So I think a huge amount of work still to be done to understand what's causing long COVID, which is so pressing given the proportion of people, the huge numbers of people who are suffering from this. We also looked at blood-brain markers and autonomic barriers and blood pressure changes when standing. Again, we haven't yet come across what is causing long COVID. So just finally, to come on to the topic of the talk and vaccine rollout in Ireland. I was really privileged. I work in James's. We were the first patient being vaccinated for COVID, and it was such a magical moment. And I remember myself, I got my first dose of vaccine because I was working on a COVID ward at the time. I got my first dose on the 30th of December, and I remember shedding tears, and I think most of my colleagues did as well. The relief of getting that vaccine is just was unmeasurable. And I think we've done really well nationally in terms of our vaccine uptake, and particularly in older age groups. If you look at those figures, really, really excellent vaccine uptake. And on an international level, I think we've one of the highest levels of vaccine uptake in the world, falling lower as we get into younger groups for a number of reasons. I think younger people are less likely to get severe COVID, and so maybe they aren't as frightened of it as perhaps I would argue they should be, having seen some young people be very sick with COVID. And obviously vaccines aren't, under 12s at the moment in Ireland aren't eligible for vaccines. So that's explaining that under 18 years, a very low proportion. I think one of the huge areas of concern to us as clinicians is around the relatively low uptake of COVID vaccine in pregnant women. And pregnant women are at hugely increased risk of severe COVID. There are a number of women in intensive care at the moment, on ventilation, on ECMO, and it's very, very dangerous for the mum, very dangerous for the baby, and really has long-term consequences for both mum and baby. So I'd strongly encourage, if you know of anybody who's pregnant, to discuss COVID vaccination with them, explore their fears. There's absolutely no evidence of risk to mum or baby from vaccination, and we have very hard evidence of very high level risk to mum and baby from COVID-19. So as our community levels are going up, anybody who has been a bit hesitant, I really would strongly encourage them to get the COVID vaccine if they're pregnant. I think I can't not mention social determinants of health and vaccination. So this is Canadian data. We don't have any Irish data on this yet. Looking at what are predictors of people being less likely to get vaccine. And you can see that, interestingly, they're actually the same people that I work with in Inclusion Health. They're people who tend to have grown up in foster care, tend to have grown up in households where there was drug or alcohol use, and have lower levels of education. So it's interesting because, as I mentioned earlier, this is the group that are the highest risk of severe COVID, and that probably are actually also at the highest risk of long COVID. So these are the groups where we really need to get vaccine uptake. And a lot of this is around information. It may be around trust between in the state, in doctors, in nurses, in the information that you get. And it may also be around different ways of acquiring education. They might be less likely, I suppose 16 to 21 year olds are probably not that likely to listen to RTE1 anyway, but we just need to be very conscious of how we're communicating with these groups. And I think I'm so proud in Ireland of how socially marginalised groups, particularly Roma, traveller and homeless, were specifically targeted for vaccination. And one of the keys when working with socially excluded groups is to build up trust. And the way that you do that is by working with that community and working with respected people in that community. And as a result, we've had really good vaccine uptake in Ireland in our homeless, traveller and Roma populations, which is hugely important. And we need to continue to keep making sure that those groups are vaccinated. So what I've learned, certainly from research, collaboration is the way forward. I was really lucky. I had a PhD student, a clinician called Liam Townsend, who did most of the work that I showed you. Long COVID is a major issue. We don't understand what's causing it. Hopefully we will in time. And that socially excluded groups and people in poverty are at higher risk of severe COVID, probably at higher risk of long COVID, and are less likely to have to take vaccines. And that is where, as clinicians and as scientists, we need to put our efforts so that we work with them to ensure that they get the benefit of vaccination. And I'm happy to take any questions. I'm conscious it's Friday afternoon. I'm sure you're all dying to finish up.
Thank you very much, Cliona, for that succinct and fascinating overview. And as usual, I have a lot of questions here. So
Great.
Give me 1 second. We won't detain you too long, I promise.
I'm more worried about the audience.
And yeah, so I'll take the first one, give you the first one while I'm reading the other ones. And they're all coming from around the country, really from our hospital staff and scientists in the laboratories and hospital staff in general. The first one is about long COVID and your opinion on this. How prevalent is long COVID? And also long COVID in vaccinated people? There's a side question, is this an issue?
So those are brilliant questions, but before I answer them, I wanted to send a massive shout out to medical scientists who I think have made an enormous and ongoing contribution to this pandemic. And I'm conscious of many, many hours and nights spent in labs. Yeah, and really thank you to all of you who are listening. Long COVID, so there's still toing and froing about what it is and how you define it. So because of that, the percentages of people in various studies differ because it differs what they're defining as long COVID and what time points they're looking at. But I think it's safe to say that at least 10% of people are not back to their baseline at 6 months post-infection. And there's a significant chunk of people who are really quite disabled from it. Some of that is people who are post ICU admission. And unfortunately, we know that people who spend months in ICU because they're immobile, they're ventilated, they're sedated, they're not moving, and the effect of the ventilation on their lungs, we know that that can cause long-term damage. And so some of what we're seeing in terms of people being still out of work post-COVID is because they were very severely unwell and in ICU. And long COVID is probably something slightly different, but again, seems to be common. We don't know yet about the effect of vaccination on long COVID. I'm hoping that it prevents it or at least reduces the risk. We just don't have that data yet.
Okay, thank you, Cliona. There was a query as to whether we could be heard here. I hope that's better. My apologies.
I can hear you anyway.
Cliona, you're perfect. You see, you're on the Zoomy thing.
Yeah.
And I think.
But I can hear you well now, so I presume.
That sounds good, actually. I think that sounds promising. One other question, Cliona, if I may, on the long COVID just has come in. And this relates to, is there an association of long COVID in healthcare workers with post-traumatic stress has been mentioned?
Yes, there is. And again, it's difficult to tease all of that out. So, and to know what direction what is going in. So some of the symptoms of long COVID are difficulty concentrating, fatigue, that overlap significantly with symptoms of depression and anxiety. So that's the first issue. I think the second issue is that there's probably a huge rate of post-traumatic stress in healthcare workers, both those who got COVID and had were very afraid for their own survival at the time, and in just work-related PTSD. And then pre-existing depression and anxiety seem to make people more likely to get long COVID. Now, again, there's a whole theory that depression and anxiety may be related to chronic inflammation. So what I don't want to say at all is that people having long COVID are people who are a bit depressed and anxious anyway. And sure, you know, I don't think that's the case. But yeah, everything is very intertwined, and it's going to be a huge challenge to try and tease it out.
Okay, thank you, Cliona. In the interest of time, I do have one more question I'll put to you, and there is a bucket of them around here, but I'll pick this one. We'll end on this one. And I think drawing on your experience in the landmark inclusion health service as well, the question is, you touched on it already actually, how do you convince people to get vaccines? And I'm fascinated as to how you managed to do that also in your socially excluded grouping. You must have a lot of experience of this question.
I do, and I think it basically comes down to relationships and trust. So it is much easier to discuss vaccination with somebody if you already have trust between you. And that is something, building trust with patients who mightn't traditionally trust doctors and nurses and staff in hospital is something we do a lot in the Inclusion Health Service, and there's many aspects to it. Part of it is just focusing on that almost, and just making sure you have time to listen to people's concerns, and that you're on some level kind of treating them as one human talking to another human, rather than me going, you should get the vaccine, get it now. And listening to what those concerns are and trying to answer them as best I can. Yeah, it comes down to building trust, I think. And in Ireland, we're really lucky because I think our high vaccine uptakes show that we still have a high level of trust between healthcare and society. If you look at the US or other countries, you can see how that trust has been eroded.
Very good. Thank you, Cliona. I think we're going to wrap up there. And by the way, obviously we're very grateful for your acknowledgement of the scientific and laboratory medicine community. Of course, reciprocated, because you certainly came across as the voice of the people, if I may put it at that.
Oh, thank you.
Connecting with people with these messages is so important in the media, to get away from the perhaps the over technical and indeed over clinical analysis that sometimes was a feature. Now, with that one, I will again thank Cliona and again for staying late.
And I'm sending a much bigger clap back to thank all of you for your massive hard work. Thank you.
Thank you. I think at this stage,